Okay, good afternoon, everyone. I hope you're all well. And welcome to today's webinar, where we are obviously going to be talking about GERDs. We've got an hour together, so we've got quite a lot to get through within that 60 minutes. And really the objectives of today are kind of just to set the scene. There's actually a few terms that I want to define. I've got a couple of stats that I'm going to share with you around things like the prevalence of GERD to give us context about how common this is. It's often just a component of other digestive symptoms and conditions. We'll obviously explore some of the underlying causes and risk factors to help us understand what are some of the functional tests that we might want to consider to get to the underlying imbalances that are leading to this symptom or condition. And obviously we will summarize at the end the evidence-based interventions that we have that have been shown to improve the condition. So this is partly to help me as much as it is to help you. I think it's always helpful to have a basic understanding of some of these different essentially diagnoses, because it helps us understand where we fit within the spectrum and where we might want to go from an investigation and from an intervention perspective. So in no particular order, we can start with the concept of silent reflux. Now, this primarily affects the voice box and the back of the throat, but it can also affect the sinuses, as can some of these other specific sort of types of reflux ultimately. And it's called silent because the burning pain associated with the acid reflux and the heartburn isn't present. So someone might not know for some time that actually they're experiencing reflux because they don't have the classic symptoms. They may end up with symptoms around things like sinusitis, or they might have a hoarse voice at times, for example. We then have LPR, and this is essentially the medical term for silent reflux. The difference between LPR and GERD, which is what we're kind of focusing on today, that these are a family of conditions, I would argue, is that LPR, the reflux is getting higher up into the voice box, for example, compared to GERD, where we're really talking about just the lower esophagus. Acid reflux is obviously related to that actual burning pain in the throat or the heartburn that we can experience. And GERD is a more advanced dysfunction of this, ultimately. With GERD, we're going to see a degree of damage that can eventually lead into other conditions and diagnoses. So then finally, we have this idea of erosive esophagitis. Whenever you see itis at the end of the word, is meaning inflammation. So erosive esophagitis is where we have severe reflux and inflammation of the esophagus, which can be seen in things like upper endoscopies, for example, where there could be ulceration or some mucosal breaks or erosion within the actual mucus layer. So that's almost kind of more end stage, a long-term consequence potentially of GERD. So we've mentioned esophagitis as inflammation and irritation of the esophagus as a result of this acid coming out of the stomach and into the esophagus. Now, Barrett's esophagus develops in approximately 10% of those with long-term GERD. And the damage that the reflux causes essentially creates this inflammation that can then go on, if over an extended period of time, to contribute to a risk of cancer of the esophagus. And there are two different types of cancer of the esophagus. We don't necessarily need to worry too much about this. Essentially, one is higher up and one is lower down. And strictures are these kind of the damage that can occur in the esophagus as a result of ongoing GERD and the erosive nature of that acid. So I just wanted to put that there because there may be some of you who have a diagnosis of LPR rather than just kind of GERD. Some of you might just know that you're experiencing a bit of reflux but don't have any official diagnosis, for example. And hopefully that's helpful just to give people a bit of background and to understand where they might fit within all of this content ultimately. And I've put it's not straightforward. It's amazing how complicated we can make something that should be somewhat simple, because we also see that actually the majority of people with reflux symptoms don't have erosive esophagitis, which is the good news ultimately. These are often going to be referred to as non-erosive reflux disease, or NERD. And this, NERDs for short, obviously. And this is about 40% of these individuals, whereby the acid entering the esophagus is actually quantifiably abnormal. Reflux hypersensitivity, we're going to touch on quite a lot later in today's webinar. And this is where the acid is actually quantifiable normal. There isn't an excess amount of acids entering the esophagus, but there are symptoms associated with these reflux events because the pH, the actual acidity of what is being sort of regurgitated or what's refluxing up into the esophagus isn't always acid. There are other compounds that can be found within that reflux. And actually, sometimes it's not particularly acid, it's a little bit more alkaline. And then functional heartburn, where acid exposure again is normal, but there are perceived symptoms that are unrelated to the reflux events. So I appreciate it's relatively complicated, but I think my sort of takeaway message from this is that we have lots of different subtypes of this, and it can be really helpful to understand where we fit within it, if nothing else, so we can have, I think, more peace of mind about our condition and the outcomes that we can expect. So then an obvious question becomes, what sort of differentiates GERD from NERD? And this paper essentially set out to explore this. And what they found was that among GERD patients, male gender, a high body mass index, high obesity degree, a high waist to hip ratio, high triglycerides, alcohol intake, smoking, and the presence of a hiatal hernia were positively related to the development of erosive esophagitis compared to NERD. Now, looking at that data in a little bit more detail, the authors said that there was a significant risk factor when we look at male gender, waist to hip ratio, and the presence of a hiatal hernia. So straight away, we're understanding and appreciating the role that excess body fat can play within GERD and to some degree NERD. These upper GI conditions have been strongly associated with our body composition. So let's get back on track. I just wanted to set the scene there. And to make sure we're all on the same page, it's worth just defining GERD for some of you maybe as well. So it's a chronic relapsing condition that occurs when gastric refluxate from the stomach enters the esophagus. And this refluxate can include actual hydrochloric acid, which we produce in our stomach, pepsin, which is essentially a hormone involved within the cascade of hydrochloric acid production, duodenal content. The duodenal or duodenus is the first part of your small intestine, but also pancreatic enzymes. So any of these in their own right can contribute to symptoms within the esophagus. And if you were to take, let's just say 10 people's reflux, and you were to look at not the consistency, the content of it, it would all be slightly different based on various things, including the meal that has been consumed. Now, the prevalence of GERD is increasing about 4% per year. It should already not be a surprise that this seems to parallel the increase in obesity, but also it parallels a reduction in the prevalence of H. pylori. H. pylori, many of you will be familiar with based on the topic of today, GERD, but it's a bacteria that colonizes in the stomach and can, but certainly doesn't always, contribute to upper GI conditions. And that can go through to things like ulceration and cancer, for example. What's really important to appreciate with H. pylori is the majority of individuals who have H. pylori have no symptoms or health issues associated with it. And therefore, there is this evolving understanding that there has to be other components to your health when H. pylori is being a problem, essentially. It is not just the fact that you have this bacteria and that's why you have condition X, Y, or Z. H. pylori is a really fascinating thing to explore in the sense that we've evolved with it for between 100 and 200,000 years is what I have read. It is ultimately an organism that we have an intimate relationship with. And in fact, you can track H. pylori genetics, and it will essentially mirror human evolution and migration out of Africa over the rest of the globe, because our relationship with it just goes back that far. In the Western world, the prevalence of GERD is 25%. So again, this is very common. A lot of people are experiencing this. So again, the question becomes, well, isn't that interesting that up to 1 in 4 people are experiencing this condition? That should again tell us that likely there are some significant lifestyle factors that are contributing to the prevalence of this condition that costs the US 24 billion annually, with the majority of that being medication. And it costs the UK 760 million a year, which I know many of you are not going to be particularly interested in, but I thought it was quite staggering the amount that is spent on this. And again, primarily from a medication perspective, PPIs, proton pump inhibitors, are really the go-to medication for GERD. So you may have seen something like this if you have been diagnosed and you went through your GP and investigation. This is one of the questionnaires that ultimately gets used in the diagnosis. So you can see over the last 7 days, how many days have you had a burning sensation or burning pain in your chest? How many days have you noticed that the contents of your stomach have come up into your throat or mouth? How many days have you felt pain in the pit of your stomach? How many days have you felt nausea or felt like throwing up? How many nights have you had trouble sleeping because of a burning pain or because your stomach content has come into your throat or mouth? GERD almost seems to peak at night, suggesting there is some degree of circadian 24-hour cycle going on here. And finally, how many days have you taken medication other than what your doctor prescribed for burning pain or because your stomach content is coming into your throat or mouth? So those are what we're looking out for within the diagnosis of GERD. And I've put this here because, again, some of you listening may not have an official diagnosis, but you may tick several of these. And obviously that is a sign that you may want to speak with your GP and have further investigation. But there are other symptoms: dental erosions, a sour taste in the back of the mouth, a sensation of a lump in your throat, a chronic cough, bronchospasms, otitis media, which is related to kind of ear infections and inflammation, laryngitis, disrupted sleep, hoarseness in the voice, sinusitis. These are all associated with a degree of reflux and GERD. And I've put in this as a little side note because a lot of people experience belching. Although it might not be one of the most common symptoms I see in clinic, when clients mention it, it's a really prominent symptom. They're very aware of it. And they're really wanting to understand what's causing it ultimately. Now, almost 50% of people with GERD complain of belching. So again, it is quite a predominant symptom within the context of GERD. And it's been thought previously that patients with excessive belching were swallowing large volumes of air, and this was contributing to it. But we now actually see that is not necessarily the case, and it can be related to involuntary diaphragmatic contraction. There's an image later in today's presentation that will give you a little bit of kind of the anatomy of what's going on here. But your diaphragm is your primary breathing muscle. It sits right underneath your rib cage, and it's in the shape of a dome or a parachute at rest. When you inhale, the diaphragm pushes down. It's one of the reasons why our tummies should rise up or out when we take a breath in. And involuntary contraction of the diaphragm has actually been associated with what's referred to now as supragastric belching. Sometimes people complain that they could belch in between meals. They can belch after a glass of water. It doesn't have to be induced by a big meal. And this is a sign that maybe there is some involuntary diaphragmatic contraction. And this may be associated with essentially things like stress and anxiety. And it can be improved, I think, through learning how to breathe diaphragmatically. And one of the reasons being is breathing diaphragmatically helps calm helps calm the sympathetic nervous system. It's essentially, put very simply, a stress management technique. So risk factors of GERD, well, older age, smoking, obesity, pregnancy, connective tissue disorders such as sclerodoma, a reduced lower oesophageal sphincter pressure, delayed gastric or stomach emptying, certain medications, we've mentioned the hiatal hernia, and impaired esophageal clearance as well. So these are all risk factors / underlying causes, some of them as well. Aggravators include some of the same factors, such as smoking, but eating a large meal or eating late at night. The recommendation is to eat really 3 hours before bedtime whenever you can, as a way to alleviate the symptoms associated with GERD, especially at night. Eating certain foods can trigger GERD for a lot of people, and we'll see a more comprehensive list later on. Certain beverages can, and again, medications can sometimes aggravate the condition. And it has been shown quite extensively now that anxiety, depression, stress are closely related to the onset and the prognosis of reflux esophagitis. So we have to be mindful of what's going on in our lives, of our mental and emotional well-being, as they really are strongly associated here. So things that we need to be considering. Well, there's what I will refer to as the slightly more conventional concepts, things like body composition, excess stomach acids, a hiatal hernia, or a weakened sphincter at the top of the stomach. But the things that I'll describe as slightly more functional, which I would also argue are very common causes of GERD, include SIBO, small intestine bacterial overgrowth, stress, low stomach acids, which we'll touch on, and dysbiosis, which is an imbalance in the gut bacteria, or infections within the gut microbiome. And these are somewhat interconnected because chronic stress, we know, can lower stomach acid production. If we have low stomach acid, we are at risk of developing small intestine bacterial overgrowth, but we're also more at risk of having an imbalance within our gut microbiome, both in the small and large intestine. And we are also at risk of picking up GI infections. If we have low stomach acids, whether or not we have or go on to develop an overgrowth of bacteria or an infection lower down the digestive tract, we're also not digesting our food appropriately. This can lead to nutrient deficiencies, which can then lead to further health issues, conditions, and diagnoses. So there's this kind of domino effect that can take place when we think about how the digestive system works. So we mentioned anxiety, depression. This is just a paper really confirming that stress has been associated with reflux as well. And some of you, I'm sure, are familiar with the doctor and the sort of international bestseller, Gabor Mate. One of his books is When the Body Says No. And one of the, I guess, themes within the book is how our personalities are associated with our health status. And he talks about how stress can actually lower the pain thresholds, and how, as a result, with GERD and reflux, for some people, it's a gut-brain problem, which means we're talking about the gut-brain axis, which I'm sure some of you are now familiar with. This idea that there's a bidirectional communication between the gut and the brain. The gut is influencing our brain function, our brain structure, our brain health, and our brain is influencing gut function as well. The vagus nerve, which is one of the highways that connects the gut and the brain, and the hypothalamus, which is a certain part of our brain, receive information from the emotional processes of the brain. So our emotional well-being is being fed into the hypothalamus and the vagus nerve, and these things are then communicating and innovating our digestive system and many other processes within the body as well. And this is the lower esophageal sphincter. You can see on the right-hand side, we have the stomach, and the sphincter is, I always describe as a bit like a trap door. Ideally, it is preventing stomach content from going up back into the esophagus. So the tone of this sphincter has a big role to play, and there's a lot of research behind how a lower tone is associated with GERD. And we know that progesterone, which is a sex hormone, fatty meals, chocolate, alcohol, and peppermint seem to, in many people, decrease the tone of this sphincter. And that is why a lot of people notice that peppermint, alcohol, chocolate, fatty meals are essentially triggers for their symptoms. Now, there's some really controversial information about H. pylori. This is a meta-analysis of randomized controlled studies. Randomized controlled studies are some of the better evidence that we have available to us. And a meta-analysis is ultimately a group of authors or researchers coming together and doing an analysis of all of those studies to come up with a conclusion from them. And in this meta-analysis, it was shown that H. pylori eradication may actually lead to the development of new erosive GERD. Eradication of H. pylori may affect neither the healing rates nor the relapse rates of pre-existing GERD. So it feels like things are changing in regards to H. pylori and the relationship between it and gastroesophageal reflux disease. Again, we have evolved with this organism for almost 200,000 years. We have to start to think about organisms and the relationship that we have with them, rather than specific organisms being the cause of disease. And this is where people talk about germ theory versus terrain theory. Germ theory is this idea that this organism causes this disease, and we know that's an outdated model. Terrain theory is the idea that our overall physiological state of health influences the relationship that we have with these organisms. And we can either have a healthy commensal relationship, or we can have a problematic pathogenic relationship. And various things are influencing this, everything from our stress levels to our sleep, to our nutrient status, to the overall health of our microbiome, and the list goes on. And I think this is one of the most important things for us to consider. This is going back to what we discussed earlier when we termed it oesophageal hypersensitivity. Other people just call it visceral sensitivity or hypersensitivity. It's this idea that some individuals are more sensitive to the signals being created in a certain part of the body. So there are individuals who can actually have normal reflux burden, but they have an increased sensitivity to it. This is something that we see in irritable bowel syndrome. There are studies where you take a group of people who have IBS, you take a group of people who don't, and I put this very simply, essentially you put a balloon into the bowel, you inflate it to the same level, and you can either objectively or subjectively analyze the sensations that are being created, or how much pressure someone feels is being placed on the bowel by the inflation of the balloon. In most people with IBS, they have a heightened sensitivity, meaning in some ways they feel like their balloon is inflated to a greater degree than those without IBS. And this is a gut-brain communication issue. And the same is true with reflux. There are some people who are experiencing significant symptoms around irritation, inflammation, pain, but they're not actually having significant reflux. So it is increasingly evident that altered perception of reflux is an important underlying cause of symptoms. Now, this is not saying that it's all in someone's head, but at the same time, it is saying that it's all in someone's head, in the sense that it's in their nervous system. There is a change in perception as a result of changes within our nervous system. We are literally feeling more as a result. And that has been associated with a few things: stress, hypervigilance, psychological disorders, poor sleep, all play an important role in enhancing perception of stimuli in the esophagus. In fact, recent daily stressful life events have been associated with symptom onset and exacerbation, and may alter perception thresholds for pain. This is a really fascinating concept, because taking it to the extreme for a second, we have something called phantom limb pain, which is whereby someone may no longer have one of their limbs, but they're still able to experience pain where that limb would be. And that shows us that there's this kind of central hypersensitivity within the central nervous system. So there's this feedback loop which seems to be kind of stuck on, so to speak. Female gender and diagnosis of IBS, a hiatal hernia, H. pylori status, and anxiety were associated with this sort of reflux hypersensitivity in the research. So there's, again, rather a gut-brain issue, or kind of an esophagus-brain issue, bearing in mind that the gut is everything really from the mouth to the anus, and therefore we could arguably still use this term of a gut-brain issue.